assess what your patient needs emotionally, physically?
So a lot of assessment in palliative medicine is through communication, is to understand the person who's the patient, is to know their life story, and then come to each symptom and try and bring it down to the maximum. And that's what builds trust. So we have, and all this, contrary to what people believe, really doesn't take time. Because history in medicine is history. So unless we know the story of the person who is in front of you, unless we know the dynamics of the caregiver with whom they have come in, how do I expect them to take notes and go for chemotherapy, go for radiotherapy, go to this building, go to that building? We put our patients through so much. And if I do not even understand the dynamics of what is going on, all this will just not have any meaning. So an assessment is important, and that's why even if you're a doctor in any specialty, palliative medicine is a training that you need to take to develop the skill to practice it.
What is important at the end of life? How well you lived your life, or how well you lived while you left your life? There are many stories told about living and dying. What is important is how you lived your life. Today I have with me a very interesting person in the studio. Let's ask her a question. Vidya, how important is palliative care in life?
Well, if you ask me that question, I have just one answer. Palliative care is very important to each one of us. It is, in fact, like a teacher once told me during my first training in palliative care. He said palliative care is everybody's business. And why? Because we are living longer. Medicine is helping us live longer. We are seeing so much of chronic disease today. We are living with chronic disease. We are learning to live with it. And so palliative care is that umbrella that we need to shield us from the rain that life is going to throw at us.
How beautiful, how beautiful.
It is definitely important.
Hello, I am Meenamma. I'm a storyteller and a trainer, and I wish to share my chats with inspirational Indians around me on varied topics of global interest, with the hope that my audience may design a better life from my episodes. Each talk is an inward journey. Come travel with me today to meet an extraordinary woman, a great human being. Do watch this episode till the end and subscribe to Meet Meenamma on YouTube, Instagram, and other handles. Today we are proud to be joined by Dr. Vidya Viswanath, a pioneering palliative care physician at Homi Bhabha Cancer Hospital and Research Center in Visakhapatnam, India. She is not just another woman. Dr. Vidya comes with a rich background in transfusion medicine and a dedicated shift to palliative care, which she made because she has been instrumental in establishing vital health services in the state of Andhra Pradesh. She holds a National Fellowship in Palliative Medicine and an MSc from the Cardiff University, where she continues to serve as an honorary lecturer. Dr. Vidya is committed to making evidence-based palliative care accessible and impactful, contributing to over 8,000 patients annually. Beyond her profession, she has a passion for classical dance and the arts. Too much said, but there's much, much more to learn. Join me as we explore her journey and the insights into the world of palliative care. Hi, Vidya. Wonderful to have you with me.
Thank you so much, Meenu. And that was a lot of introduction.
Vidya, palliative care is something that people are hearing of in recent times more often. What is palliative care?
Okay, so thanks for bringing that up first, because you're absolutely right. I mean, a decade ago, or maybe a little more than that, it's 25 now. So in 2012 was when I started my journey in palliative medicine. And that was when, coincidentally, like the universe guides us, the first hospice came up in Visakhapatnam, the fledgling start to the first hospice that came up in Visakhapatnam. At that time, I was even asked, oh, palliative care, is that a placebo? That was the question I was asked when I started my first training. But having, seen that era, and today in 2025, I'm really happy to say that we have patients who come and ask us, is palliative care available? Which for me is a huge thing. So what is palliative care? All of us must be having somebody who has either a chronic kidney disease or a liver disease or cancer at home. And they would have watched the lives of these patients up close and really at a personal level. So we understand that medicine. And why did palliative care come up? It's not like cardiology where a new stent came up or a new branch of medicine, like you had so many advances in neurology that you needed a separate branch. You had so many advances in gastroenterology, you needed a branch. But palliative care came up, and this is not my words, this is what Dr. Brennan says. He says that it came up because medicine lost the vital touch. In our world of technology, somewhere we started looking only at the disease. We stopped looking at the person with the disease. So what palliative care does is look at the person with the disease, travel their journey together, help them go through their most difficult times, and then, approach the whole disease, the whole person actually, holistically. So it provides for the physical, the psychological, the social, and the spiritual domains in healthcare, which is what we absolutely need. And when I say disease, I mean chronic disease. I don't mean if you have a fracture, there are 10 hospitals in one road which will take care of you. But suppose you have somebody who's paralyzed at home. Every hospital will just tell you, we don't have anything to do, please go home. So palliative care teaches us never to tell a patient that we have nothing more to do. True. So I think that is the key aspect of palliative care. It's holistic medicine. It's a lot of touch. It deals with the whole person. And it also teaches doctors not to tell patients that there's nothing more we can do, because there's always something that we can do.
As you walked into the studio for the recording, it's 8 in the evening, and you've had a hard day's work. And when we asked you, so how difficult was your day, you answered saying, it was not as difficult as my patient's day. It was such a meaningful sentence, Vidya. You travel the day with people who are in intense pain. You spend most of your day, almost half your life, holding hands of patients who have serious illnesses, and also some of them are dying. How do you describe your day, and why did you select this profession?
So a lot of people have asked me this. They keep saying things like, don't you think it's very depressing? Don't you think it's difficult? But I would like to think of it on the contrary. It actually has given me so much. I would call practice of palliative medicine as a privilege, because you are with somebody when they are their most vulnerable. And when do we need help? To cheer us, or when we are happy, we have so many friends around. You throw a party, you'll have so many friends visiting you. But the day you fall sick, and the day you fall sick with chronic disease, the day you cannot move out on your own, the day you lose your self-image, the day, disease takes its toll on you in multiple ways, you have very few friends. And at that time, when the doctors tell you that, we don't have anything to offer, there's no more disease-directed treatment, you can go home, I think that is abandonment. So in my mind, I think I chose palliative medicine because it teaches us non-abandonment of the patient, and it teaches us what is continuity of care. We all know that the reality of life is death. That's a one thing that we can't change. But we can definitely live well till we die. So palliative care for me is about living. It's about living well till you die and helping someone navigate that. And when you see suffering all day, you just feel grateful for every minute that you have. I mean, and I would feel sadder if there is no one practicing this, because that is what would probably depress me, that you are watching suffering but you don't know what to do. But now when I train and I at least know what I can do to bring down that suffering. I can never say take it away, because no one can take away somebody's suffering completely. But when you can, bring that down, or you can mitigate it, I think that is what fills me with, whatever it is to go back to work the next day. So,
Vidya, you open the door into a room of despair. Actually, there is a lot of sorrow in the room that you work in. People have given up on their life. People have given up on them. And there you are like an angel. You walk in and hold their hand. How do you assess what your patient needs? Emotionally, physically, that they're in a position of, there is no end to that pain, or wherever they are is difficult, very difficult. They're going through the worst of their life. How do you assess what they need from you?
I think that is what training teaches you. When somebody walks into the room, there is a sense of intuition. By now, most of us are able to read body language. We are able to sense what they feel. But in palliative medicine, we pay a lot of attention to communication and proper assessment. Because, the body language, there's so much of communication in palliative medicine. It's about how I turn my chair and how I sit with my patient. We are always taught, sit at eye level. Because the minute you stand above your patient, you're already towering over them. The person who walked into my room is not going to feel comfortable talking to me. And pain is multidimensional. We always talk about pain as total pain. We never call it as physical pain, because pain is multidimensional. It's the components are physical, psychological, spiritual pain. I'm talking to you today. If I lost my voice tomorrow because of a disease, that would give me a sense of immense sadness. So that's because I cannot teach, I cannot talk to my patients, I cannot do the things that I once did easily. So for each person who comes in through those doors, we know that they have lost something very meaningful to them. And because I work in a cancer hospital, most of my patient stories come from cancer. So today there was a patient who came into my OPD, and he was so disheartened because he used to cycle every day and he took great pride in cycling. He asked me today, will you allow me to cycle for just a little bit in that garden? I said, of course I will allow you. Why not? I mean, just try. He said, because I'm so tired. I was the same person who used to cycle 6 rounds in the park without even batting an eyelid. And now I am not able to walk my cycle to the park. And I don't want to do it because I don't want anyone to see me like this. So the elements of, that spiritual pain, but all this will not come if I sit there and look at my computer and try and take a history. So a lot of assessment in palliative medicine is through communication, is to understand the person who's the patient, is to know their life story, and then come to each symptom and try and bring it down to the maximum. And that's what builds trust. So we have, and all this, contrary to what people believe, really doesn't take time. Because history in medicine is his story. So unless we know the story of the person who is in front of you, unless we know the dynamics of the caregiver with whom they have come in, how do I expect them to take notes and go for chemotherapy, go for radiotherapy, go to this building, go to that building? We put our patients through so much. And if I do not even understand the dynamics of what is going on, all this will just not have any meaning. So an assessment is important, and that's why even if you're a doctor in any specialty, palliative medicine is it's a training that you need to take to develop the skill to practice it. So it's not something that I just decide to start doing and doesn't just happen like that. So
it's not just medical communication.
yes.
It's a psychological,
Yes.
I say that you do an entire study,
Yes.
a psychological study of your patient,
Yes,
where they
yes.
come from, where they are.
Very,
So
very true.
communication and assessing his history is so important.
Is very, very important. And also at every stage in the disease trajectory. At diagnosis, the psychosocial dynamics would be different. As they go along the treatment trajectory and things are working well, there may be a difference. When things go bad, when there are transitions, there again you're going to have a completely different dynamic, because now this person's going to tell you, I got diagnosed, I went through all this, I did all of this so well, and look what has happened. So, dealing with that, dealing with a recurrence, dealing with something that has come back is again difficult. And then end of life care conversations are a completely different. So that's why we always insist that even volunteers working in palliative medicine need to train, because in each part of the disease trajectory, how you communicate and what you say is very, very important.
What you do not say is more important, isn't it?
Yes, what you do not say, your own body language. And I may be having 10 things in my head, but I can't let that influence my behavior with my patients. So I have to be very mindful about these things too.
Tell me, whenever we say palliative care, most people think it's for cancer. Is that a myth, or is palliative care mainly for cancer?
It's definitely a myth to be busted, I would say, because palliative care for cancer, yes, it was a catalyst for palliative care, definitely. Cancer was the catalyst for palliative care because we absolutely needed it in palliative, in patients with cancer. That's when the field started developing, but today we deal with subspecialty palliative care. So we have something called as ICU palliative care, we have nephrology palliative care, we have neurology palliative care, we call it neuropalliative care, nephropalliative care, cardiopalliative care, respiratory palliative care. And why do I say that? Because think about neurology. Each one of us can immediately think of at least one patient or one person in either our family or in our friend circle who has either dementia or Parkinson's, or they have some kind of neurological issue or a stroke. It's something which is not rare anymore.
Yes.
And the number of patients who are on dialysis with chronic kidney disease, it's unbelievable now.
Correct.
Similarly, you have patients living with ILD, which is interstitial lung disease, with COPD, which is chronic obstructive pulmonary disease. So these are so commonplace today, all of these diseases. And diabetics whose kidneys, they have retinopathy, they have nephropathy. So each of these diseases, they are chronic, which means that there is no cure. And look at the frail elderly. Correct. We are all living longer, we take pride in that. But at the same time, medical science hasn't advanced to that level that you are going to remain the same as 90 as you were at 50. Your body is definitely going to change. You are going to get more frail. And then what happens? How do we deal with frailty in our elders? How do we deal with our elders with all of these diseases? So that is where a huge part of palliative care comes in. And we can't leave the children behind, because we have neonatal palliative care now. We have pediatric palliative care, which are again growing into important subspecialties, because there are children who are born who hardly get any time in this world. There are a lot of children who have chronic disease. There are a lot of children with different kinds of cancers. So all of these also require palliative care, because palliative care provides the kind of support that you need alongside your disease-directed therapy. It's not a substitute, but it works alongside whatever problems that you have, and that's where its beauty lies.
Many people think palliative care is only for the dead and dying. It's end of life care. Is that true?
That again is a myth, because palliative care encompasses care when you are diagnosed with something like a chronic disease. It starts from then, and then it can be stepped in between and out, or it can just follow the trajectory of the disease. So you could be taking treatment, but you could also be having palliative care. So we have different definitions. We call it early palliative care. When you have the resources, like what we practice at our institute, we have patients who have access to early palliative care. So the minute they are diagnosed with what we call as disease that has already spread, or with metastatic disease like we call it, at that time itself they are introduced to palliative care. So the trust building starts, and we look after their pain, their symptoms, that initial adjustment of shock, of trauma, everything that the family goes through. And then we actually see that beautiful cycle, when initially we are there, and then once treatment starts, then the patient says hi to you from the corridor, which we also feel good about, because they are doing well with treatment, they are getting better, they're feeling better. So the symptom burden is not as high. And so they come to us whenever they need. And then gradually, as the disease progresses, as the disease burden increases, and the symptom burden increases, they again come back to seeing more of us. But because the relationship has been built, they do not find it like, a place where you have to go when things go wrong. We are like their companions along the journey.
Yes.
And so that's the beauty of early palliative care. So we call this early palliative care. And then along the trajectory of the disease, we call it as concurrent palliative care. And what we provide towards end of life is called end of life care. So end of life care is a very, very important component of palliative care, but it's not only palliative care or all of it.
Yeah, especially in diseases like cancer, terminally ill diseases.
Yes.
Towards the end, it's difficult for the family also, to balance it. So like a hospice, I guess these are all avenues where a palliative care expert comes in use. And what about, I have a list of things that are myths. It's only for those who are poor, underprivileged. Why do people feel like palliative care is only for those poor people? The rich people don't need it.
I really wish I knew. In fact, I feel sometimes that, the patients whom I see every day who are predominantly the underprivileged, they have access to better palliative care than those who are affording. Because it's very sad, and this is a trend that we have seen over the years too. Like when our grandmothers died, or maybe one generation even before that, they usually died at home surrounded by their family. They had a doctor who came and visited them at home, or access to somebody at home and the family around them, and that's how they passed. Whereas as medical advances grew, we started rushing everyone to ICUs, and then we started seeing way more deaths in the ICUs. Now, that is why ICU palliative care. We are again coming, I'm hoping that we are trying to come back at least a bit, and understanding who needs to be in the ICU and who doesn't. So in the justice of the medical system, the ICU is for those who need it. But who needs it? The people who have an acute condition. And the people who, say a snake bite, a myocardial infarction, things like that, you definitely need an ICU. You need it for many other things. But somebody who has advanced disease, somebody who's in a place where their disease is never going to get cured, and they are never going to be the person that they were. These are not patients who should be living their last few hours in the ICU.
Very true.
So, it's commonly said the rich die in the ICU and the poor die neglected. Yes. That's the sad state of our country. So, rich or poor, disease doesn't see that. So, anybody with a chronic disease is going to need palliative care at some point, unless you're extremely lucky to have a death like, say, Abdul Kalam or somebody like that, a sudden death, which happens at about barely a very, very minuscule percentage in our country, or in the world actually.
How do you handle cultural sensitivity when someone is dying or a relative is dying and the family is already in shock? There's a whole ecosystem of pain and the cultural shock. How do you handle this?
So that is where the need for early palliative care comes in. See, if you're going to tell me to handle a family where somebody is dying and that's the first time I'm ever meeting them, it's going to be next to impossible. It's almost impossible, because where is the time to build trust, to build what we call as prognostic awareness? All of these things, there is no time. So that is where early palliative care comes in. So I already know this family. And we also have what we call as, we are trained in our communication to actually plan for all this even in advance. So we recreate those scenarios. We say, what if this happened? What would you like to do?
So you prepare them
We
earlier
prepare
in
them early.
advance.
And
Okay.
in the wards, we always ask our patients, where would you like to be? Things are not looking good, so where would you like to be? So like you said, we have to be respectful of the cultural, sensitivity, and be sensitive to, their cultural needs, because we have patients who tell us when things are really bad, because we want the last few breaths at home.
Yes.
So we plan accordingly. There are some patients who tell us that, there was in fact one young lady whom we looked after, who used to keep coming to the hospice. She loved the hospice. She loved all of us, but she made me promise one thing. She said, if things go wrong, I want to be in the hospice when I die, because I do not want to be at home, because I don't want to be remembered as, that bed, that place should not be the place where I died. I don't want my family to remember that. I want to be in the hospice. Whereas for some patients, being at home is very sacred. And we also have to be very careful and ask these questions, because there are times when the villages refuse to have somebody who has died to be brought in.
Yes.
So then the relatives tell us, we are very worried, we are going home, because we need to be home. We can't take him home once there is a death. So I cannot at that point ask them that, why are you telling me this? So it's in that time my duty is to make the arrangements so that is facilitated. So we have to be really mindful culturally. And all of this, it really helps, because we have these conversations. And so even when death comes, it's that minute everybody is around, and they actually come back to talk to us and tell us, and how grateful they are that they could be with their loved ones. So I think that is a huge privilege of palliative medicine.
For all those who are watching, pain has no language, but it's a great communication effort to speak the language of pain and death. I hope you're enjoying this conversation with Dr. Vidya Viswanath. If you've forgotten to subscribe to Meet Meenamma, do it right now so that I can get more people like her on the show. Coming back, Vidya, what about the family's involvement? How do you decide how much the family should be involved in the palliative care sessions?
We are quite demanding of families, actually, because I feel sad about that sometimes, because this was brought up by one of my own staff once. He said, ma'am, we expect the family to be there. We expect them to work. We expect them to look after the patients. We expect them to feed, make sure they're fed on time, their medicines are on time, they cannot be moved, to look after their toileting. Aren't we putting too much on them?
Yes.
We are. I agree that we are, and we do, but family caregivers go through a lot, and that is why the definition of palliative care includes family caregivers. So we look after their needs too. So that is why we always talk to the family caregivers along with the patient. We also, when we feel that there is a need, which is quite a number of times, we also talk to the family caregivers separately and to the patients separately, because sometimes caregivers cannot express how tired they are in front of their patients, and we can see it. So we have to teach them, we have to make them feel less guilty about going out, doing their own thing, which is also important. And we also have to make things easy for them. So that's why we provide home care. We go to patients' homes. In palliative care, it is like the old-fashioned physician who goes to patients' homes, and where we do, whatever is possible from our side, we help the caregiver out. And the family also feels good that, at least I have help coming home. So the caregiver is at the center in a lot of distress.
What is the role of having an interdisciplinary team in palliative? You're not a one-man army.
Oh, absolutely. We have an intradisciplinary, interdisciplinary, multidisciplinary. So our teams, the palliative care team, in fact, has no hierarchy.
Yeah.
We quite pride ourselves on that we try and say that we have no hierarchy because each one is doing their role. So we have doctors, we have nurses, we have the psychologist, and then we have the social workers, and all of them, into the team. And also the paramedical, like the roles of occupational therapist, physiotherapist, they are beautiful roles that they can play. So that's where the interdisciplinary and intradisciplinary and all of it comes in, because and I know that all palliative teams across our country do not have access to have all of them all the time.
Together.
But most of our palliative care teams, if we don't have them within our teams, we have access to them. So then we can work together. Because to achieve what we call as meaningful integration, I can't be talking to the patient one day before the patient passes. And my oncologist cannot refer that patient to me one day before or hours before. That's meaningless, because it's absolutely no point. So building relationships with your colleagues and with your oncologists, like because I work in a cancer hospital, is also very important. And that's where the training comes in, because I have to have adequate knowledge on the subject to be able to hold a conversation with the oncologist. And then they start trusting you with the patients, because for everybody wants their patient to get well. So, for that trust to believe. So relationships between teams, between colleagues, between patients, between families, it's a village out there. So
I'm trying to map your mind, Vidya. You get up every morning and you have to run into a room full of pain people, but they're looking forward to you because you're the beacon of hope. What is your personal motivation to do this job?
I think I would feel terrible if I saw pain and couldn't address it. That was my motivation, actually, because and my motivation came because I worked in the blood bank. That's also a social medicine. And that was where upfront I saw children with thalassemia. I saw patients who had chronic kidney disease. And in those days, the days when I was practicing transfusion medicine very early, oncology was not so advanced then. So you didn't have the GCSF and the factors which stimulate your bone marrow to produce blood. So at those times, we used to give blood transfusions. And I used to meet those relatives. I used to meet all of them who would come for multiple transfusions. All the patients with chronic kidney disease and their relatives who would come for multiple transfusions, the children with thalassemia, their parents. So I watched chronic disease really closely, and I interacted with all of these caregivers. And that is when I found that, you want a pediatrician, you will find many pediatricians.
Yes.
But you want somebody to look after only these patients, it's hard.
True.
Similarly, when things are really bad, when these children are in a difficult situation, when patients are close to dying, or when disease does not have any cure, suddenly everybody is told, go home, go home.
Yeah, there's
And
no question.
I don't understand what going home means. I mean, I couldn't go home in a state like that. I need you the most now.
Yes.
And that is when I started reading about palliative medicine, because I just wondered what it was. I did not know the name till 2011, honestly. And that was when I started reading.
Is this an old sub thing of...
Yes, about in the early 2000s, we had already started palliative medicine. Very small pockets, but the first 1994 was when it actually started in India as a movement in parts of the country, and of course in Kerala and in Gujarat. But then the first MD in palliative medicine, the academic program, and recognized by the National Medical Board, and first MD started in 2012.
Oh, it's a relatively new
so
field.
It's a very young field, and that's why we are waiting for more MD palliative medicine graduates to come. I have one working with me, so I'm really happy for that. But the thing is, it's a relatively young training specialty, like we call it. So I think when you can't do something, that becomes your motivation to want to find, to do something.
So you are now, you all are still on the starting line, and I see your department. I visited your department the other day. There are so many young people there.
Yeah.
So you still look forward to more people coming in.
Yes.
But you people are going to be the seniors for the country. You see, very soon people will understand. But what is the impact of palliative care today in India?
See, if I were to say, I would say it's slowly making inroads. That's where we are. Globally, we are nowhere. Still, we are far behind. Because globally, and here it's interesting to know that actually good palliative care practices and most of our learning comes from UK, comes from Australia, comes from Canada. US will come after, because there it's more insurance driven. Whereas most of our training is UK based and Europe, and these are the countries which are pioneers in palliative medicine, and they've done really, really well. When we compare that, India is, we have a global index, and we are not at a level which is like we have palliative care provision everywhere. That's not the level that we are in. But having said that, the map looks definitely way more colorful today than what it did 10 years ago. Because 2012 we started the MD training programs, and we started a lot of programs. So I'm faculty for multiple training programs in the country. So so these training programs help people start palliative medicine in their own institutes. Wonderful. And having done that, I don't think there's any state now which does not have access to palliative care.
That's really good.
Yeah, I wouldn't say all districts, but all states is a definite yes. Kerala is unique.
Ahead.
So there you have palliative care everywhere. Telangana is not far behind. And we are still getting there. In the whole of Andhra Pradesh, I would say now Tirupati, Guntur, and Kurnool, these are places where there is palliative care. But there too, like departments have started, and we have enterprising people who have really started, oncologists primarily. But non-oncology palliative care is still way, way behind.
What is the advice you'll give for a patient? How does a family member know that they are patient, or the patient know that they need palliative care?
So, we have this, how do you tell somebody that they need help? So this is actually, it's there in one of our journals too. So if you wanted to go from, say, Visakhapatnam to Vijayawada, and I gave you a Mercedes-Benz, and I gave you a Maruti car with all the safety precautions. I gave you, and by safety I mean simple things like a proper steering, a brake, the basics of a good car. I gave you that in a Maruti. I gave you a fantastic Mercedes which had none of these safety precautions, or none of these. What would you choose? Because this is, along the road you're going to have a lot of bumps. You're going to have a lot of areas where you are going to need help. And you can't bypass all of that and get to the very end. You will be, it's going to be disastrous.
Yes.
And like I said before, palliative care is the umbrella, it's not the rain. So many times people think that, referring to palliative care means, all is lost. But all is not lost at all, because we all want, good for the patient.
True.
So whatever specialty we are doing, that's our final goal. So if we work together in doing that, it actually adds so much value. So palliative care is about that safe car which has all the safety precautions that you need when you're going for a bumpy ride.
How do you explain this to the patient or his family?
So to the patient, we tell them, when they come in for early palliative care, they sometimes wonder, they said, we were sent here. So we were sent to OPD 109. So then I sit them down, and I always teach my youngsters that this is your best chance, to talk about palliative care. So I tell them, as your treatment is going on, this department is going to look after you. Any problems that you have, it could be pain, it could be breathlessness, it could be any symptom that you have, or anything there, anywhere that you want to unburden. If you want a safe place, this is your place. We are all here. So as you don't have to take a different appointment on a different day for us. The day you have your chemotherapy appointment, the same day when you're waiting for your laboratory reports, please come and meet us. So then the patient starts feeling, okay, this is not an additional extra that's been thrust on him, but this is a place where they're going to get help, which is exactly what we do. We provide help for symptom control, we provide navigation support, we provide the psychosocial support. They come and tell us things like, I have to travel 250 kilometers to come here, and I'm on a weekly regimen. So there are times when I've gone back to the oncologist and asked them that, this is a genuine problem. He will fall out of treatment because he's not going to be able to do this. So is there another regimen that you can, especially when I know that it's palliative chemotherapy? And they do it. So it's these kind of things, they are not comfortable talking to it's hard to tell your oncologist, right, that I travel from here, he's giving you treatment, you feel blessed.
Yes.
But these are the little nuances, even these things my nurses will come back and tell me. They are more comfortable with them.
True. Are there any organizations or sources that people who want to get into active palliative care can, do a program or a workshop or training? Would you suggest something?
Yeah, of course. I think any palliative care center will usually be working with an NGO. In our country, it's very, very common. So some of the biggest NGOs in our country that we have, they are like Pallium India, Can Support, Palcare in Bombay. So you have, and Can Support is all over the north where they do home care. Pallium India is in the south and going. So we have a lot of these organizations which support palliative care. And in our own Visakhapatnam, we have Aged Care Foundation,
Correct.
Which started as an NGO in 2012 to support both geriatric and palliative care. And today it's grown into, we never imagined that 13 years later, it's, there's a separate building now, and the hospice can cater to almost 200 patients. So it's where there's a will, there's a way. And so you do have NGOs which, help in training. And we also plan to start a volunteer training in our own institute this year, because World Hospice and Palliative Care Day is coming up in October. 11th of October. So because for that we thought we would initiate a volunteer program also. So because it's important that those who want to volunteer also train. They have to understand at least the basic nuances, and that is when they themselves would feel comfortable talking to patients. Otherwise it would be hard. So
it's wonderful having you, Vidya, with me, and time has just flown by. So much to ask still, but I'm a very proud palliative medical clown. My husband and I are very happy to be part of your tribe.
Thank you.
We're able to, in our own way, see the pain that you go through and convert it into a purpose for us. So, the warriors that you all are, palliative care medical doctors, it's a thankless job. Your patient
I wouldn't say thankless at all, because just, the eyes of your patient when you talk to them, what you get from that, and it fills your day, it fills your heart. So I think we should be grateful to it, So
I'm so happy that I have an angel like you sitting next to me today, Vidya. Wish you
Meenakshi.
all the best. And for all those who
you.
are watching, life is a journey between a womb and a tomb. It's always this little distance that you and I are trying to cross, and pain is inevitable for many of us, but suffering is not. So whenever pain comes your way, remember, there are warriors like Dr. Vidya and her entire team of palliative caretakers who can help you, who can hold your hand and let you walk into a dignified end. So it's not important how we live, it's important how we die. We should die happy, cared for, with our dignity intact. And if you forgot to subscribe, do subscribe to Meet Meenamma. And remember, unless you subscribe and let me grow, people, great angels like Vidya cannot be here. Thank you so much. God bless you. Stay healthy and stay hopeful that there are always people to help us. Thank you.